Hi, everyone. Welcome. We're happy to have you all here. I'm Diane Lang, and I am happy to present to all of you Maria Motsavage. She and I worked together years ago at UHS, and I'm really happy to have her come in and start our series, our three-part series on issues for seniors. And I thought Maria would be a great one to kick off because she has so much great information for us. So let me give you a brief introduction here. Okay, Maria has an extensive background in community health. She is an RN, and she worked for 18 years in community health nursing. She also pioneered and implemented the first long-term health care home health care program in Broome County, which is significant. She was president and CEO of Ideal Senior Living Center in Endicott from 1994 until 2012. And then in 2012, she joined Levene, Gouldin, and Thompson. And there she is an elder care coordinator. And she holds a certificate in elder care coordination. She's also a certified court evaluator and a member of the Life Care Planning Law Firms Association and an individual associate member of the American Bar Association. So she works on advising families and seniors on long-term care options, which the longer you live, you may have to think about, including services in the home, and also criteria for admissions, which is very important. She also works on conducting home safety assessments and in coordinating services in the home. So I need to also tell you, for those of you online, if you would like a copy of a handout in the chat, put in your email address and we'll send you a copy of it. The rest of us have it in person here. Okay, does everyone have a handout here? Okay, great. And so now I'm going to turn it over to Maria.
Good morning, everyone. I'm not going to be referring to this right now, so you don't need to watch the screen right now. Well, thank you for having me. Diane, thank you for inviting me.
Thank you.
And there are familiar faces here that I'm so pleased to see, Judy and Mary Lou. Mary Lou actually followed me at Ideal. So it's just a pleasure to see. Can you hear me? Okay, pleasure to see all of you. Thank you so much. So as Diane said, I'm an elder care coordinator. Hope this is okay. But quite frankly, sometimes I think of myself as a travel agent. I don't know about these guys back here, because I have learned over my 45 years that middle-aged adults and older adults don't shop around for assisted living and long-term care. You know, they don't send away for brochures about nursing homes or assisted living. They don't get online and look at what the accommodations are, what's a semi-private, what's a private room. They don't look at the amenities in nursing homes. Certainly don't look at the reviews and the star ratings when they're still healthy. So I hope my takeaway for you today is to at least have some information. So if the time should come that you or a loved one are faced with some choices, that you at least have some things to remember and some options. Okay. Also, my business cards are back here in case any of you are interested in that. I worked with Judy's husband as well at LGT. So the scenario I like to start with is the family that lives out of town, who have a mom living here alone. They call every week. Mom says she's doing fine. They come home for Thanksgiving and lo and behold, mom isn't doing so fine. The refrigerator is full of expired foods. The bathroom's not clean. Mom hasn't showered. It's apparent that mom needs some help. So for the next 3 or 4 days, they're scurrying around, calling people, looking up resources to try and figure out what can we do for mom? You know, what do we do now? So home care is certainly always the first option. Everyone wants to remain at home. And I would tell you that pre-COVID, it was a pretty viable option to get some home care aides in to assist with that. Post-COVID, it's a challenge. The labor pool is shrinking considerably due to a number of factors. Some of them were out of work for a long time, the vaccination requirements. Many of them have started up their own little private groups of aides because they don't want to be told where they have to go and how long they have to work. They want to do privately and set their own rates, etc. So if there's some informal supports, if family is available to do some of the things, and you can find aides for the hours you want, for the days you want, home care can still be an option, and it is for many. But for those who need someone for 8 to 16 to 24 hours a day, it is nearly impossible. And I do this all the time, trying to secure aid services. So it's not always possible. The first other thing to think about is the home still safe for mom to be in? One of the things, as Diane said, I do is a safety assessment. So I walk through the house and identify what might be a risk for mom to stay here, even with home care coming in. If she's still getting out of the house, how many stairs are there to get in? Are there railings on both sides? What's the flooring like? Are there throw rugs? Does she walk with slippers or sneakers? Because it makes a huge difference. Does she use a 3-wheeled walker or does she use a cane? All of which have different hazards, exposed to them. Are there stairs to get up to the bathroom and living area? And if there are there railings on both sides? Are they carpeted? Once you're up there, is there lighting at the top of the stairs and the bottom of the stairs? In the bathroom, is there a raised toilet seat? Most older adults do much better with a raised toilet seat, easier to get on and off as our joints, and I'm having my knee done in another month, as our joints start to fall apart. Are there rails on the side of the toilet? Is the tub an old-fashioned regular tub that she has to step into? And if so, are there grab bars? Is there, if she can't get over the tub, is there a transfer bench you can purchase so that she can sit and just swivel? I'm saying she, this could be a father too, can swivel into the tub. Or is it a walk-in shower? And if so, there should be bars inside the shower as you get in. So lots of things to think about. In the bedroom, is the bed high, low? Can he or she get in and out of it okay? Do they need a commode next to the bed if they can't really make it to the bathroom? So if the home is safe and he or she can still be okay in it, then home care may be an option if there's enough available. The second thought families have is, well, is it time to bring mom into our home? Should we bring her here to live with us? Because that's what families do. At least that's what families did a long time ago. But things have changed because that family may be a working family and their kids may all be in school. So is the situation any different during the day than when mom was at home if no one's home with her? And if mom's issues happen to be that she wanders at night and that's the safety issue, is someone willing to be up all night with her? And then you get to, is our home safe enough for mom? And the same things I just did for mom's home, I would do for the family's home. Are you willing to make modifications to your bathroom? Are you willing to get rid of those nice, fluffy, beautiful rugs in your bathroom and replace them with a Home Depot rubber-backed indoor-outdoor rug, which is what I recommend, because if they don't slip, if it gets wet, you're okay, and they don't look anything like you'd like your bathroom to look, but they're safe. So there's just a lot of things to think about. We brought Dad into my home. He lived with us for 6 years, and I learned a lot. I learned a lot about how to make my home safe, no matter what it did for us, for him. And if you do bring that person into your home, anticipating their needs while you're gone is so critical. Mary Lou, you'll know this from the nursing home world. If an aide doesn't anticipate what's going to happen when they walk out of the room, the call bell's going to be ringing. So I learned very quickly, because I was working, that before I left the house, if I didn't put his TV remote, his rosary, his handkerchief, his coffee on the tray, by the time I got to LGT, my phone would be ringing. So, anticipating can cause a lot less stress for the family members, obviously. Oh, by the way, if you have questions as I'm speaking, raise your hand or just yell it out. You don't have to wait till I'm through. So that's kind of the home care situation, things to think about as a loved one's independence starts to change.
Maria, just briefly, before you move on, we have long-term insurance we pay for every year, have for years. And I keep thinking, what's it worth? Because
I've got to chat on that later with Medicare, but I will talk about that now. Anyone else have long-term care insurance? Oh, wow. That's impressive. Very wise middle-aged adults when you purchase that. What I'm finding now is that the home care clause, the home care coverage for long-term care, though you may have a great policy with good dollar amount, is very difficult to qualify and very difficult to find the aids. Most policies require you to be unable to perform 2 activities of daily living for at least 90 days in order to qualify for the home care benefit. And when they come to assess you, they want to see that you absolutely cannot do those by yourself. That you either need someone in the room with you or you need someone with hands-on assistance. And that's what disqualifies most of my clients that are trying to get some benefit out of that expensive long-term care for home care. The other thing is some policies, depending on when you bought them, require the aides to come from a licensed agency. Okay, that's a huge issue now because back in our day, Family and Children's Society was a huge home care agency. When I ran home care, they had 250 aides. Today they're closed. They went from 250 to 100 to 20 to closed. So though we have aid agencies available, the population of aides has dwindled. So if you can't find someone in a licensed agency, as I said, most people through word of mouth are finding these private groups. Most policies are not covering the private aides. You know, we've had to do some appeals if the aide worked in a nursing home, if the aide worked in home care and has a certificate. Some policies will okay it because they know the situation here is so dire. But home care coverage is a challenge for long-term care policies. Sometimes you have to fight like heck. As far as nursing home and assisted living coverage, much better, much easier. Policies that were written before 1998 don't talk about assisted living because there was no such thing, but most of them are grandfathering it in under alternative care and different language that's in their policies. I do a lot of reviews of long-term care policies and try and summarize for our clients, you know, what does this mean? If I need it, and I may need it now, you know, how do I get it? What do I have to do? But home care, yeah, is a huge challenge. Thank you for bringing that up. So you've exhausted all the home care options, not enough for mom. Mom or dad really can't stay in their own home. Then I'm going to start talking about this first handout I gave you. So in Broome County, we are very fortunate that someone is still very independent and just doesn't want to take care of the outside, but they can still go grocery shopping and they can still do their own meals. Then they may want to look at some of the senior housing options. The Office for Aging puts out a beautiful document about every year, every 2 years, called Senior Apartment Housing Guide. And I don't have this as a handout, but you can go online on the Office for Aging website and print it out. It's got all the senior housing with the criteria, the financial criteria, and the rates for whatever year. This one was published in 2020. I believe they just put a new one out. But it's a wonderful document if you're thinking, I need to leave my big house and move into an apartment. So I recommend that. The ones that I've listed for you in the beginning is independent living. So if you're not ready yet for anything other than leaving your home, these independent living are called campus models, which means they sit on a campus, which in addition to apartments, also has assisted living, nursing home, and some of them have home care. So it gives you the ability as your needs change, as your medical condition changes, to perhaps move to another level of care. So as you can see, lots of different rates. These are the monthly rates for 2022. They differ for a number of reasons. The organization that owns them, the semi-private room, well, they're all semi-private because they're apartments, where the apartment's located. The biggest difference is the difference between Good Shepherd Fairview and Good Shepherd Village. Good Shepherd Village, out of all of these, it has a different licensure. They are licensed as a continuing care retirement community, a CCRC. And as such, their regulations require them, if you move into an apartment, if you pay the entrance fee, as your needs increase and you need assisted living or you need nursing home care, they have to be able to provide you with that on their campus. If not, they do look at their Fairview campus. But it's a guarantee that these other campuses are not required to provide you with. So if you move into United Methodist Homes, Hilltop, one of the cottages or apartments, or Ideals apartments, or Fairview apartments, and you become more ill and you need nursing home care, they will do everything they can to try and keep you on their campus. But if there are no beds available, they will ask you to look elsewhere for placement. So that's the biggest difference. Questions on that? Okay, so that's independent. So the next page,
Can I ask you, the Elderwood Waverly, that's the one in Vestal by the JCC?
no, actually, I put this together when I did a Tioga County presentation. This is actually in Waverly. The Elderwood you're going to hear about next is in Vestal. That's the next level of care. They don't have independent living, but thank you for saying that, because I forgot I did this for Tioga. So the next least medical model is called the adult home or adult care facility. People who just can't maintain their own homes anymore and now need someone to cook for them, now need someone to make sure they get their medications every day, but medically they're still stable, can do very well at this level of care. It's called an adult care facility. It's still licensed and regulated by New York State, but it is a residential model of care. It is not a medical model of care. I'm sorry, my back's to you guys back here. So you have a room, you go to a dining room for all 3 meals. Your medications are, so you get assistance with your medications from an aide. Your laundry is done, your linen is done. So very little do you need to worry about. You get to socialize in common rooms. Transportation is available in most of them to take you to the grocery stores if you want to get groceries in your room, but there are no kitchens. Kind of like living in a college dorm. It's a bedroom and a bathroom. Everyone looks a little different. You can see the rates are all different. Elderwood Village at Vestal that you just brought to my attention is the one on Country Club Road or Clubhouse Road, across from the Jewish Community Center. That used to be called Woodland Manor, and then it was Emeritus, changed names a few times. United Methodist Home St. Louise is located on the Elizabeth Church campus next to SUNY Broome on Front Street. And then UHS Senior Living at Ideal is in Endicott. So they all provide that level of care if you're appropriate for that level. Okay, so far? Then the state started to complicate things tremendously because New York State, and its infinite wisdom, created after this another 5 levels of assisted living, different licensures, different requirements, different retention standards. In the late 90s, they started what they called the ALP, the Assisted Living Program. And it was a brainchild to combine residential living of the adult home, but bring in some home care. So if people still needed some home care, they had to contract with an agency and they could come in. There's no nursing care on site. There's a nurse working there during the day, but her role is really to provide case management. If you need to go to a hospital, kind of walk you through that. If you need someone to talk to your doctor, do that. But they don't provide nursing care. So though it's a half medical model, it isn't for people who have really acute medical conditions. The biggest difference between this model and any other model I'm going to talk about is they were required to each facility have a limited number of beds that Medicaid would pay for. So if you are on Medicaid and there's an opening, one of their Medicaid beds, you can actually have Medicaid pay for your stay there. Everything else I'm going to talk about, including the adult home, Medicaid will not cover. Long-term care insurance rarely covers that first adult care facility because it's so residential. But most long-term care policies will cover the assisted living program, and the rest of them I'm going to talk about. Because when they look at why you were admitted, it has to do with your inability to perform all those activities by yourself.
Can I ask a question that relates to that? So on the first level of care that you showed us about the campus models, the Medicare clearly doesn't pay for when you're, as you say, independent and can look after yourself. But as you progress through the stages, if you end up in full nursing, does that kick in at some point or not?
I'm going to talk about that when I get to that level. Yes.
Right, okay. Sorry.
For right now, good morning. For right now, these are private pay out-of-pocket prices that you're looking at. Medicare, 65 and over, doesn't pay for any of this except nursing home care and some limited home care that I will talk about when I do the Medicare basics piece. Okay, so far? I know, it can be overwhelming. I don't want to overwhelm you, so trying to give you enough to think about and to know what's out there. So I've listed for you on the bottom the assisted living program facilities. And as you can see, some of them are the same as the adult home because they offer both. They have, for example, Ideal has 2 floors of adult care facility and assisted living. So today, September, you may be in adult care. Things change, and in November, you now need more help. And guess what? You're in the same bed in the same room, but you're called an assisted living program resident. So you're now getting a little more care, and guess what? You're paying a little more money. So the newest one out of all of those is the Pavilion at Vestal Park. Vestal Park is the newest nursing home facility. It's up off of Sheedy Road, way up Route 26. Yeah, way down. If you're going up 26, you look down, it's a beautiful campus of Vestal Park.
Above the parkway.
Yes.
Almost exactly.
Yes, that's the most recent addition to assisted living program.
Coconut Creek.
Yeah.
I know, everyone's first reaction was, why would you, this is the nursing home that flooded in Vestal 3 times. Why would you move there? And yet they tell me that area is never flooded. I don't understand it.
I know.
That's what they say. Father, do you have a handout? Okay. So again, feel free to ask questions as you can. So the next page, again, this is that infinite wisdom of Department of Health. So these are 3 new levels of care, and they're all a little bit different. The assisted living residence, the ALR, the enhanced assisted living residence, the EALR, and the special needs SNALR. So the idea behind this creation was that individuals would be able to age in place and perhaps not require nursing home care. So they set it up so that there would be nursing care available 24 hours a day. There could be aid service available. They are in place there. And if your needs could be met and be affordable with their rates, then you'd be able to stay at that level of care. So many people come into the ALR level. And again, as their needs change and the facility says, we really can't give you an aid just 1 day a week. You now need an aid morning and night. You need an aid to cue you, to help you in the dining room. We're now going to place you with our EALR program. Again, same bed, same room, but you're getting more care and your monthly rate has now changed. Those are those 2. The SNALR was designed for people with memory care issues, people with dementia, people with other cognitive issues. It was designed with a more secure area, so you can't get out to wander as you could in other parts of the assisted living. Aides in the beginning, I can't say they're still doing this. We're really specially trained in dementia and dealing with people with dementia. We try and do a lot of education with them to help them with that. So they are called the SNALRs, and I've broken them down here on this sheet. Again, at every level you look at, you can see the rates going up. More care, more aides. Staffing has become an issue with any of these facilities. Good Shepherd Fairview actually closed their ALP, hopefully temporarily, because of staffing issues. So it's much more difficult to get into a facility than ever before. I do this every day, again, trying to help people move into facilities if they can't stay at home. I have better luck getting them into these types of facilities than I would get into the nursing home that I'll talk about next. Again, all private pay, no Medicare coverage, no Medicaid coverage. Those of you who have long-term care insurance, God bless you, you'll most likely get coverage if you need to move it or a loved one needs to move into one of these. Other questions on this? Okay, so the last page are the skilled nursing facilities. So if mom now can really not be appropriate for those other levels, she needs 24-hour supervision, medical supervision, needs are changing more quickly, then most likely, or she's bedbound, most likely mom would then need to look into moving into a nursing home. As you can see, the rates have about doubled from all the other pages. Nursing homes are getting very, very expensive. You can pay out of pocket. Your long-term care insurance can pay. If you're on Medicaid, you run out of money and apply for Medicaid, Medicaid will cover this. Or short-term Medicare will cover. And we'll talk about that when I get to Medicare basics. It will make more sense. So as you can see, these are the options here. I can tell you right now, since COVID, unless you're moving from a hospital to a nursing home for rehab, it is almost impossible to get into one of our nursing homes if you just need chronic care. If you can't live at home alone anymore and you need someone to take care of you, it is nearly impossible to get into one of our local nursing homes.
I'd like to add one thing about the private rate.
Mhm.
And you say somebody is on Medicaid. Medicaid does not pay the price that you're seeing here. Medicaid, again, regulatory restrictions. The provider gets a percentage of a private pay cost. So don't think that Medicaid is just, Broome County is just going to come in and pick up the tab totally, because it
Really,
doesn't.
it's like less than 2/3, yeah. Which is why nursing homes don't survive if they have 70, 80% Medicaid people living there. They can't afford to pay their staff. People cry, why aren't our staff getting paid like hospital nurses? The facilities are not getting reimbursed like hospitals are. I mean, when you look at Mary Lou and I tried to balance that budget, very, very difficult with what Medicaid pays. What I do want to impart upon you though, because so many families think, well, once mom goes on Medicaid, they're not going to take care of her the same way they did when we were paying $12,000 a month. You know, the fact is the staff have no idea who's paying the bill. I mean, they only pay for semi-private rooms. So if mom was in a private room and she goes on Medicaid, most likely she will soon be moved to a semi-private room. But the staff don't know why. The care should be no different. I just want to make sure people know that because I hear that a lot. Oh, she's not getting the care she did because she's on Medicaid. It's really not true. Anything else on nursing homes? Okay, big variation in prices, as you can see. And they go up at least now 4 to 5% a year. So people will be getting notices by December that their rates are going to go up if they're paying privately. If you're paying privately and you look like mom's going to be there a long time, I would highly recommend you start talking with an elder law attorney about finances, about what you should or shouldn't be doing to, if you want to protect some assets, because there's still a spouse at home, or there are children, mom would want to protect assets for. Elder law attorneys can look at all the finances and help determine, is there some opportunity here to move finances to another spouse, etc., so that when she runs out of money, it'll still be okay to apply for Medicaid. I'm not doing a Medicaid presentation. I don't do those because the attorneys do those, but I will say you've probably all heard about the 5-year look back.
Yeah.
So what Medicaid does is look at when you do apply, you know, they would see all your check registers for the last 5 years, all your bank statements for the last 5 years, and the real estate transactions for the last 5 years. And if it appears to them that any of that was gifted to someone other than the spouse or a disabled child, in their minds, that was done to get on Medicaid, and therefore we're going to deny you. And if you're denied, it's a very convoluted formula on how they determine how many months penalty you'll have to pay before that you can be approved for Medicaid. So I encourage people, I'm not trying to sell elder law services, but if it looks like somebody needs nursing home care and you want to protect some assets, no matter which law firm you go to, you want to speak with an elder law attorney, at least to have them look that over and give you some advice.
Any comment about spousal impoverishment?
Yeah.
Again, I'm not an attorney. They don't like me to talk specifically about it, but I can say that there is an opportunity for spouses to not become impoverished because their loved one's in a nursing home. There are things that can be done to allow them to keep much more assets. And if I can't say a lot more about that, but yes.
Along the same lines, Maria, when you're talking about qualifying, I assume that all means that there is no spouse or family member available to provide care. In other words, if you have anyone at all that can be a caretaker for you, then you're not going to qualify no matter what daily thing.
For Medicaid?
No,
Oh.
to get into the places.
Oh, no, you can. It really has nothing to
Is that
do with
right?
that.
Yeah.
Oh, yeah. Oh, yeah.
Yeah.
Yeah. If you look appropriate, just you, not paying any attention to your family and whether they're going to take care of you or not, you can certainly qualify for assisted living and be admitted.
And sometimes isn't there an arrangement whereby if you are a family member and are a primary caregiver, where the caregiver can receive some income doing that?
Oh,
job?
Oh, yeah. Yeah, for nursing home. When you're home, yes, it's something called a personal care contract. So if in fact a family member is being paid, I hope this is okay for these people watching me at home. If someone's being paid to help at home, in order for that to not disqualify you, a personal care contract has to be drawn up by an attorney, which says, I'm going to do these things for mom or dad. And then you're going to keep a very specific log every day, every hour of what you did. Did you do checking? Did you do grocery shopping? Did you give them a bath? And how much you got paid for all of that. Because if you don't do that, and that checkbook shows $500 a week going out to Judy as a spouse or someone else, they're going to suspect that was a gift. There's no proof that what you were doing was caregiving. Now, if you give $10,000 a year to your only grandchild because you have lots of money, that doesn't necessarily disqualify you. Because if you've done it over a period of time, some caseworkers, I can't say all, next door, or not, they're not next door anymore. Some caseworkers will say, oh, they've been doing this. They didn't do this just to get on Medicaid. They've been doing this as a wonderful grandparent for their grandchild. But if you're more frail and all of a sudden you're given $20,000 for your loved one or your grandchild to go on a trip to Aruba, they're probably going to disqualify you. Thank you for raising that.
One other thing that might comfort some people, that with their children, if the person goes on Medicaid, that the children are not then responsible for any of the financial part of their parents' care. So you don't say like, oh gosh, now I have to pick up the tab. No, that's against the law.
Right. What they do require, however, is when you turn in that financial application for mom or dad, that's the amount of money that facility is counting on being there to pay their bill. So if they see all of a sudden year 3, those $2 million are now down to 1,800, there's going to be a problem because they know that the family was obviously doing something. So what you are, if you sign that, what you're signing is, yes, I promise to use mom or dad's money to pay for their care here. And that's all you're saying. You're not promising to use any of your money or funds. It's mom or dad's money. That's what they have, and that's what we'll use to pay for their care. Thank you, Mary Lou. Okay, so far? Everybody thinking, oh my God, I got to look at my bank accounts tonight. It's scary. It is overwhelming. And until you're in that situation, like I said, people don't think about it. You're wise enough to get the long-term care insurance. Okay, so I'm going to switch to Medicare now. If there are any more questions about levels of care. Okay, so I want to talk a little bit about Medicare. Most of you probably know all of this, but I like to refresh people. Right arrow, right? So all of you are on Medicare, I assume. And do all of you know whether you have regular Medicare with a supplement and a drug plan, or you have a Medicare Advantage plan? You know the difference, good. Okay, so I'm going to talk about those differences if you don't know, because they're kind of important. So Medicare coverage, despite no matter what kind you have a Part A, which you get when you're 65 or earlier if you're blind or disabled, is your hospital insurance. So it covers an inpatient hospital stay, but this year the deductible was $1,556. Also covers nursing home, which I'm going to talk about shortly, home health, which I'm going to talk about shortly, and I don't know how to get rid of that little box, but hospice care. So it also covers hospice in the home. Your Part B, everyone's paying Part B out of their Social Security checks, most likely, is your medical insurance. So that covers your outpatient, your doctor visits, your x-rays, your physical therapy, your MRIs, your CT scans, some medical equipment, depending on what you have and what your doctor orders for you. This year's deductible was $233. So after you've met that, Part B covers 80% of everything else. So you still have a 20% bill unless you have supplemental, which I will refer to. The premium this year to pay for it was $170.10, higher if you have more money. I'm hearing that's going to go down next year. It'll be the first time ever in the history of Medicare. But I am hearing Part B is supposed to go down. So more money in your Social Security checks. Stop me anytime. Okay, Part C. So when I talk about Medicare Advantage plans, at how many years ago? How many years ago do you think these popped up? 15, maybe?
How many years?
How many years ago do you think Part C plans came up?
Oh, gosh. Yeah. 10 anyway.
Yeah. Okay, so the government decided they would contract with private companies to offer Medicare. So these plans, there are 65 of them in our area alone. You have 65 options to choose a Medicare Advantage plan. And these plans still require you have A and B. So you still need your red, white, and blue card. You still have to pay that premium. But if you don't want to get the Medigap policy, the supplemental, these plans offer the same coverage. And some of them offer vision coverage, some offer dental coverage, some offer hearing aid coverage, and many of them offer 0 premiums or very low premiums. So they're very attractive. They're on TV all the time. They're at your door. They're sending out mailers. You know, the incentive is you only have to pay us $10 to get all this coverage, or no bucks to get all this coverage. You need to look closely at what the coverage is, because the dollar amount is not necessarily the same as what you're getting. The inpatient stay, even though they have to cover it, they don't have to cover the same amount of dollars. Same thing with the medical procedures, etc. So they're wonderful for people who are not very ill, people who don't have a lot of chronic problems. They're great plans because they are less expensive and you very rarely utilize the services under Medicare C. I'm going to go back for a minute. So what you want to watch out for if you are purchasing a Medicare Advantage plan is talk to your doctor. Think about what hospital and what nursing home you might choose if you needed to, because they contract with those folks. Not every doctor has to contract with Excelis or Aetna or Touchstone. Most of them contract with Excelis, but they can pull out anytime they want to from your provider. If they don't think they're getting enough money from that nursing home, they void the contract. So we have many people who have Medicare C plans that need rehab in a nursing home, and they want to go here only to find out that it's considered out of network and they will not get the coverage from it. So, think about that when you're purchasing a plan. Medicare enrollment is starting October 17th, 15th, and goes through December. If you want to look at your plans, if you want to talk to someone about your plans, Action for Older Persons is one of the agencies that does that. If you're familiar with them, it is free Medicare counseling. You need to call now to make an appointment. They will look at all your medications with you, talk to you about how often you go to the doctor, how much you're spending on these things, and then they will show you all the plans. They'll tell you which one to choose, but they will show you what each plan covers for you. So I highly recommend you do that if you're not sure and you want to make a change. Okay, Part D is a prescription drug benefit. If you have an Advantage plan, you don't need to purchase a prescription drug benefit because they're covered. Your meds are covered. Different amounts, but they're covered as part of your Advantage plan. If you have the red, white, and blue card and a supplement plan, a Medigap policy, then you have to purchase a Medicare D plan. There are lots of them available as well. And that's one of the reasons I go to AOP every year, is because those rates change constantly. That coverage is constantly changing by the year. If you're on a lot of expensive medications, it's really good to take a look from year to year. Supplemental plans, anybody know if they have a Medigap policy, a supplement plan, AARP, United Healthcare? Okay. Those are some of the supplemental plans. So if you have A, B, and D, it's like an alphabet soup story. You probably, if you can afford it, want to buy a supplement plan because they will cover that 20%. So A and B are covering your 80%. This often covers your deductible for Part A, and will cover all the 20% coverages. They're not cheap. They're expensive. But again, AOP will help you look at how much are you spending going to the doctors? How many times a year are you routinely in the hospital? And will it be worth your while to spend this money? AOP again. Action for Older Persons. They're located right now on Plaza Drive, 200 Plaza Drive. 722-1251. I give that number out a lot. Okay, so let's talk about the Medicare coverage in nursing homes because it is tricky. Those of you with regular Medicare, the A, B, and the supplement plan, if you are admitted to the hospital. And I mean admitted, not sitting in an ER for 3 days, not under observation, which I'll talk about in a second, but actually admitted. And the doctor says, you really need to go to rehab for a while. You're not ready to go home. You need some therapy for a few weeks. Medicare will cover that for 20 days in the nursing home if you've been in that hospital admitted for 3 days, not counting the day of discharge. So unfortunately, what we have happening a lot here are these observation stays. And if you had experience with an observation stay with a loved one?
One time and never again. I learned my lesson.
Good. So you take your mom to the emergency room, appears very ill to you. 8 hours later, they're still trying to figure out what's going on. 20 hours later, they're still trying to figure out. And she may or may not be there for 2 days. And then you decide she can't go home. She's got to go to the nursing home. And lo and behold, it's a surprise. Nobody's going to cover this because she has not been admitted for 3 days. So hospitals are required after 24 hours to give you a form. It's called a MOON. It's the Medicare Observation Form to tell you you are under observation. Therefore, nursing home coverage will not be paid. Your Part B will pick up the things you have done in the hospital, but they really don't cover Part A. Not many people are being billed for it. But it would serve you well if your loved one is in an ER to ask the question, is she still under observation or is she being admitted? Because they may in fact put her in a room and she may be in a regular bed and you think they're admitted and they're not. So be very aware of that. What was your experience with observation?
Well, it was for me personally, it was somebody else. So, yeah, no, exactly what you said. Not that I needed to go to, I just got a big bill.
Yeah, right. Right, because what Medicare
so
won't
I
cover.
wasn't
Right.
admitted.
What if they're now runs to the hospital, hence you're stuck in the ER? They can't let you out of the ER if you're too sick.
They can still admit you and leave you in the emergency room. Yeah, the big question is, am I an admission or not? And the doctor has to determine that. As far as the nurse,
Walk out with ER anytime.
Oh, I know.
You can sign yourself out.
Yeah.
I've done that.
Against medical advice is a good idea.
right, especially if you need some care at home, because doctors don't like to sign home care orders if you signed yourself out. If you have a Medicare Advantage plan, those of you who don't have the ABD, they do not require that 3-day qualifying stay for nursing home. So if you have that plan and you're in the ER and you go right to a nursing home for rehab, then you're okay. They're gonna pay the stay. Not too far. Okay, so this is what happens with Medicare in rehab stays. So for day 1 through day 20, whether you are an Advantage plan or regular, for those first 20 days, Medicare will pay completely as long as during that time you require skilled therapy, physical therapy, or occupational therapy, or speech therapy, or a skilled RN to really do a procedure on you. Okay, the minute those things, or you don't want to do it, or you can't do it, or you're not benefiting from it, Medicare will say, we're done. Day 5, no more coverage. It really depends on that need for therapy. So most people get through the 20 days. Kind of unusual for it not to be. After day 20, from day 20, when everyone says, I have 100 days of Medicare, people in the hospital will tell you, don't worry, mom's got 100 days, no problem. Not true. She has a 100-day benefit. But at any point during those 100 days, again, if they don't need the therapy, they don't want the therapy, they're too sick to go to therapy, Medicare can stop that coverage. So from day 21 to day 100, they will pay everything but the $194.50 a day. That's a copay. If you have a supplement plan, the Medigap policy, almost all of them will pay that. So you don't have anything to pay for. The Medicare Advantage plans do not pay the copay. So you will still have a copay to pay. After day 100, Medicare covers nothing if you're still there, even if you still need therapy and you're paying everything. You're paying the full cost. Again, anytime a therapy is not required, you're out of luck. What happens is you or your representative will get a notice from the nursing home. It's a non-coverage notice. They have to give that to you 48 hours before they cut you off. So pay attention to that, because in my experience, that's not always happening. And we've been able to fight some of those non-coverage letters. So they should say in 48 hours, Mom or dad's no longer going to be covered because of the reasons I just said, and you will become private pay, and this is the rate you'll have to pay. If you disagree with that, if you say, they're not ready to stop therapy on mom, she still needs this, then you have the right to sign an immediate appeal. And I tell everyone to make that appeal because it forces the company that looks at this to re-review it, to look at the documentation. They may still deny it, but at least you've made an attempt to get them to approve it. So I always tell people, you can do 2 or 3 appeals. It goes higher and higher up each time. If you're denied, you are going to have to pay the bill from the date they gave you in the beginning. Sometimes it buys you like another couple of weeks of therapy. So after day 100, if anyone's actually received therapy for 100 days, unusual, the coverage ends, as I said, until a new benefit period starts. So you have to be without therapy or home for 60 days before that benefit period starts again. When it starts again, everything starts again. Day 1 to 20, 21 to 100. Have I lost all of you or any of you? Okay.
Good.
Okay. So this kind of tells you about the breaks. If it's less than 30 days, whether you should keep this for your information, whether you need another 3-day qualifying stay or not, whether you need to pay the co-pays or not. So I won't go through all this with you, but the important days are the 1 to 30 and 60. Home health coverage. So we talked about getting a home health aide in. Back when I used to do this, there was a lot of home health aides still available. So in order to have an agency come in and provide home care, and you don't have long-term care insurance, which may not be able to cover, there are certified home health agencies here. Lourdes Home Care and UHS Twin Tier. They are the only certified home health agencies in Broome County. If the doctor orders it and you're homebound, which means you can't get out regularly by yourself, you need someone to take you to the doctor, then Medicare will cover a nurse, short periods of time, like once a week or twice a week. They will cover a therapist to come in, PT, OT, speech, and they will cover some home health aid time. If there's an aide available through those agencies, they'll cover a couple of days a week for an hour or 2. No Medicare coverage for 8 hours a day or 4 hours a day. Those days are long gone. So it's very limited, and it's usually at the most 6 weeks of coverage, at the most. It's usually if you've come out of the hospital with post-injury, post-surgery, or you've had a very bad medical condition. Observation status, I probably already covered all of this. Medicare doesn't pay, you're under observation, they have to give you the moon, but just pay attention. Always ask the question. Let those staff know that you know what you're talking about. The consequences, you found this out, there's no Part A coverage. So you get a bill from the hospital because you're under observation. If you don't have Part B, almost everyone does, then you have to pay for everything. Okay, meds are not covered under observation. So some people have been lucky enough to turn their medication bills into their Part D plan, but they do not have to cover them. So you may be paying for the medications. And the number of days you're under observation doesn't count. I have had people go into the emergency room under observation for 2 days, get admitted because they decide they're ill enough for another 2 days, and then need nursing home care. So now they've been in the hospital 5 days, and guess what? Rehab stay is not covered. So they've only admitted for 2 days. So, observation is like a real key word now that you have to use. And there is no appeal process. Medicare, I don't know why, refuses to establish an appeal process for observations. They tell you you're under observation. You can call your doctor, your primary doctor, and see if they have any influence at all with the hospitalist. My experience has not been good with that, but you can try to see if they can get you admitted or not. But there's no other appeal that you can appeal. What can you do? I just told you that.
Maria, what's the benefit to the hospital for keeping you under observation and not admitting?
Because they won't get penalized. If they admit you and there's a review process, if they admit you and that review says, oh, they didn't need to be admitted, they don't get paid. They don't get paid at all. So there's quite an incentive not to admit.
Okay.
I mean, there is a 2-day midnight rule. The doctors are supposed to, if it looks like you have to be there at least 2 midnights, it's called the midnight rule, they're supposed to admit you. So you can always ask for that. What about the midnight rule? And pretend you really know what you're talking about. But yeah, that's the incentive. They don't get penalized. Okay, that's kind of it for me. It's a lot of information. Yes, sir.
Just a quick question. Will we be able to download this? Guys, you're gonna put it somewhere where
Yeah.
we can get to it?
I assume you're okay with it.
Absolutely.
Yeah, so it'll be up with the Trinity forums. It'll be online.
Okay, no problem.
There may be a bit of a gap till we get it up.
No, it's good stuff. It really,
Absolutely.
Also, each of you probably get this in the mail every year if you're on Medicare. So, you know, everything I put in this little summary is in here if you want to read the book. And actually this year, for the first time, they have all of the Advantage plans in here with their coverage. That's rare for this. So if you want an Advantage plan or you want to meet with AOP, you know, take this with you and go over it with them. Anything else I can?
So what's the difference between an Advantage plan and the other plan that,
The Advantage plan, A, is cheaper.
right?
The advantages are it's cheaper. It offers some things that regular Medicare doesn't: vision, dental, hearing, depending on, they're all private. The downside is that not every doctor contracts with them, so your doc, and they can stop that contract anytime they want to. So today, Dr. So-and-so may be covered. Next week, the plan pulled out and they're not covered anymore, and you're now scurrying for a new plan. That's the biggest difference. Not every nursing home contracts with every Advantage plan. So there are some Advantage plans that hardly any nursing home contracts with. So as I say, you have to weigh all of that when you choose.
And what's the other option then? If you don't get an
Option is A, B, D, and a Medigap policy, a supplement plan like AARP.
Oh, regular
United Healthcare,
supplemental.
yes.
Oh, it's either Advantage or supplemental.
Right,
Okay,
exactly.
great. Thank you.
Any other questions? I hope I've enlightened you a little bit. So I hope that was beneficial.
Terrific, yes.
And my cards are back here. Fortunately or unfortunately, I can't work with anyone unless you are a client of the firm. So if someone needs my services, I get lots of calls to say, oh, I listened to your presentation. I need you for my mother. Mom has to become a client of the firm first. I have to meet with an attorney with me or without me who will go over the financial pieces and try and guide them into what, and the legal pieces to make sure their power of attorneys are done properly. Make sure they have healthcare proxies done. They do that piece. And if it looks like most of what you need is me, then I work with you.
Great.
All right. Well, thank you for having me.
Thank you so much.
Thank you. Thank you.